if a member of the family is afflicted with cancer, it can sometimes lead to the bankruptcy of the whole family. Is this statement factually true? And why doesn't 3M take care of that? I mean, I'm puzzled, you know. Could you comment, Pin Min?
Well, I mean, I don't know whether this is really factual or not, but if you look at the 3M framework, it does cover quite a fair bit of the catastrophic admissions to hospital. I think it's not a perfect system, but the beauty of the 3M system is that, you know, the MediSave component actually forces the person to save up, you know. And this MediSave component can then be used to pay for the co-payment. So if you look at an admission to hospital, although there is a co-payment system, the out-of-pocket, you know, from the patient is actually can be almost negligible or quite minimal, all right? So whether it will lead to the bankruptcy of the entire family, I mean, I don't think I can comment on that. But having said that, in a lot of my contact with residents at the Meet the People session, I hardly come across many residents who come to me to say that, you know, I do not have money to pay for my medical expenses. Okay, most of the issues are related to other aspects, such as housing, transportation, etc. But I hardly come across a resident who comes to me and say, I don't have money to see a doctor, you know, I can't afford it. I think one of the problems is that some residents may not be aware of the schemes that are available. For example, Medifund, you know, if you are really, really deprived or not able to afford medical expenses, normally I would advise them, you know, if you visit the hospital, the medical social worker will try to help you as much as possible.
Yeah, Jeremy?
Yeah. If I go back to really Balaji's comment, it's because there is cancer treatment and there is cancer treatment. The government's assurance is of basic medical care. But oftentimes, the bar for basic hasn't caught up with what are internationally recognized guidelines. And it's very difficult for really family members to go back to their loved ones to say the government will pay for X. X is very cheap, can afford. But Y is what you would get if you were in America, Australia, etc. But it will bankrupt the whole family. What is the choice that we should make? And it is in that context that really the funding mechanisms haven't caught up. But I think we need to realize that our strengths are also the challenges that we face today. The reason why we can spend less than 4% GDP is because the co-payments are high, because people are deterred from basically over-consuming care. But when the co-payments but when they are too onerous, people may refuse medically necessary care, and then we suffer poor outcomes, or really people may spend beyond their means. And the system doesn't protect the individual from when it comes to the financial burden. I don't agree with Paul, actually, that we should abolish the 3M model. As a former MOH policymaker, policymakers want to have levers. And with MediSave, MediShield, MediFund, subsidies, there are sufficient levers that the government can adjust. In a single-payer model, if the government runs into financial difficulties, what then can it do? It raises premiums, it increases the co-payments, it gets voted out, the next government comes in and says, we can solve this problem. And I think that's the challenge that many single-payer models have been struggling with. I frankly have no confidence that the PAP government or any other government will be able to resist public opinion. And hence, speaking as a former policymaker, I think that our 3M model allows policymakers levers. But maybe the last comment I would make is to share a tale that actually Mr. Ngiam Tong Dao shared with me over dinner once. He said that sometime in the 60s or the 70s, a famous Harvard psychologist was called in to basically conduct tests on the admin service. And he said, wow. And he went up to the then Prime Minister, Mr. Lee, and said, Mr. Lee, this is the most brilliant group of individuals I've ever seen, I've ever analyzed anywhere in the world. say, oh, that's excellent. But their compassion scores are quite low. Right? But their compassion scores are quite low.
Compassion score.
Right? And perhaps that is the challenge that our system faces. We have a very beautifully, very cleverly designed system, but if the compassion, the adherence to rules becomes very excessive, becomes very rigid, that's when we run into problems.
Could I should open up the floor, but let me just ask one question. Could I just ask all four of you a question? Obviously, America is not a model. Yeah? Obviously, the NIH model, UK, is not a model. If we look around the world, is there any country, any territory whose healthcare system contains teachable lessons that we can learn from? I mean, dare I ask all four of you, is there anything we can learn from Taiwan in this respect?
Well, I've been doing a lot of comparative healthcare systems the last 20 years. And let me tell the other side of the Taiwan system, because in recent months there's been this fascination. No? And let me tell the other side, and this comes from the previous Minister for Health, who's a good friend of mine, Professor Yong, who resigned 2 times on the whole issue of raising premiums. And in fact, when we invited him to LKY school 2 years ago, he privately told me, he says, if I were to do it all over again, I wouldn't go for a Singlepayer system.
Would not go, no?
Because it's politically unsustainable. The pressures then will be on government or the National Insurance to keep on dishing out more, and then you're supposed to collect the premiums. So politically, every government, whether you're right wing or left wing, PAP or SDP or whatever, will find, you can promise the world and give it, but then later on, how are you going to collect the premiums? How are you going to raise the fees? So in Taiwan's case, just to push it up, every few years they have to tweak it, they push up for maybe 3/4 of a point or 1, he was asking for 1.5. He says that will save me for the next 2-3 years. And again, inflation will catch up, and then the next government have to persuade the people to pay more premiums again. Okay. So it's always easier to give than to actually take back, And in the context of an aging society, you're going to have a serious problem, because there are going to be more and more old people who are going to be demanding for this entitlements or welfare once you put it in a scheme that is free or heavily subsidized. And then you're going to find who's going to be paying, either taxpayers in the younger age groups or the younger productive members who are going to pay the premiums. So unless you're going to change it and say, okay, go forward towards a savings-based scheme. In fact, that's what Taiwan actually would have liked to do, which is to put a savings base first before you put in the insurance.
Okay. So anyway, your answer is no. Huh? Paul?
Yeah, I don't know too much about the Taiwanese system, but everyone seems to be citing this WHO study that was done once and never repeated. And the top healthcare system in that study, if I'm not mistaken, was France. And France is a universal, France was #1. France is not an NIH system. France is not a US system, but France is actually a universal health insurance kind of system where they have, if I understand it, private players and there's mandatory health insurance. So everybody has to buy health insurance, and then the payers in order to get this mandatory insurance, they are not allowed to exclude people for pre-existing illnesses, which I think was the dream of Obamacare, which whether it's going to happen or not is another story. So I think the French system is one of the things that we need to do. And I would argue that if MediSave, MediShield, MediFund is only 15%, then the rate of healthcare inflation is unsustainable in Singapore, because it hurts businesses, because they're going to have to spend more and more and more money. So in fact, healthcare reform in the United States was driven not by the public so much, but by the businesses who felt that they were paying so much out of pocket. So I think that's the reason why there has to be some change. And I think the 3M system, it just has to be revamped.
Okay, thank you. Pin Min, your comment on
Taiwan system, I don't really know that much, but I've read about it, and that because of the low co-payment in the Taiwan National Health Insurance Scheme, it sort of encourages Taiwanese to actually seek consultation, and sometimes over very unnecessary problems as well. So there's this danger of overuse, or what they call the buffet syndrome.
Yeah. Okay. I think it's now your turn to ask questions. Who would like to start? You? Can you go to the microphone?
Thank you for your wonderful presentations. Really enjoyed it very much. Having lived in Taiwan and Japan, I want to say that the Singlepayer system works. And actually in Taiwan, there's a lot of reforms.
Could you introduce yourself?
Hi, my name is Wayne Sun, and I'm a PhD student at Princeton.